Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. Here's Dr. Weiner.
November is Pancreatic Cancer Awareness Month, a time to raise awareness about one of the most challenging cancers to diagnose and to treat. You may not know that pancreatic cancer is currently the third leading cause of cancer-related deaths in the United States, and it's estimated that over 64,000 Americans will be diagnosed with it this year. But there is some good news, including advances in early detection and some new innovative therapies that are both here and about to be here, and supportive care strategies that have evolved for patients. To help us better understand pancreatic cancer, there is no one better than Dr. Jill Lacey. Dr. Lacey is a well-known medical oncologist, researcher, professor of medicine at Yale School of Medicine. And although Dr. Lacey has been involved in many different aspects of cancer care, she really focuses on gastrointestinal cancers and specifically pancreatic cancer. Her work has contributed significantly to improving outcomes for patients facing pancreatic cancer, and she is someone who both succeeds in individual patients' rooms where she helps individuals and their families, but also through her research has tried to have a much larger impact on all individuals with pancreatic cancer. Jill, thanks so much for joining us tonight.
Well, thank you, Eric, for that kind introduction. Pancreatic cancer is indeed a challenging cancer, and I think the statistics tell the story. So you mentioned that there are 64,000 cases diagnosed per year. There are 52,000 deaths per year from pancreas cancer, so the death rate almost approaches the incidence. And that simply reflects the sobering lethality of pancreatic cancer.
And that's really quite different from a lot of other malignancies. So, for example, breast cancer, there are over 300,000 cases of breast cancer and 43,000 deaths. So a woman and occasionally a man diagnosed with breast cancer stands a pretty good chance of not losing their life to it. On the other hand, you hear a diagnosis of pancreatic cancer, and in 2025, it's still, unfortunately, more common than not, far more common than not, that someone will ultimately lose their life.
Yes, so that is all true. The 5-year survival for this disease, although it's tripled over the last 2 decades, which is an accomplishment, it still sits under 15%. And for those patients who present with advanced disease, very few are long-term survivors, with less than 2% making it to 5 years. So what are some of the reasons for these very discouraging statistics? And we'll talk more about this. So there are a number of challenges that we're facing with pancreatic cancer. And I think first and foremost is that in most patients, the diagnosis is made late. Most patients, 70 to 80%, are diagnosed when the disease is already locally advanced and inoperable or metastatic and inoperable. And thus, these patients are not curable. Now, we can treat these patients with advanced pancreatic cancer, but even with the best treatments in 2025, the prognosis really remains limited.
So when people come in, with their locally or sometimes even more advanced pancreatic cancer, what are the kinds of symptoms people have? And I guess the other question I have is, how long have those symptoms been going on?
So really, the question is, why are so many patients diagnosed so late? And there are a couple of reasons for that. First of all, we do not do routine screening for pancreas cancer in the general population, so that we don't have that opportunity for early detection. And it's the presence of symptoms in most cases that will prompt a workup that leads to the diagnosis. The pancreas is an organ that lies deep in the abdomen, so there are not going to be any lumps or bumps or masses. And these tumors tend not to cause any symptoms until the disease is advanced. And the symptoms are often quite nonspecific. A little bit of indigestion, a little bit of discomfort after eating, maybe a change in bowel habits, maybe a little bit of weight loss, common symptoms that we all experience here and there. Oftentimes, these symptoms have been present in retrospect for many months, even a year or longer. Now, a few patients, well, about a third of the patients will present with an alarm symptom of what we call jaundice, yellowing of the eyes and the skin, and darkening of the urine. And that is a setting where we often do make the diagnosis earlier when the tumor is operable. So those are some of the challenges with making an early diagnosis of pancreatic cancer.
And does that presentation with jaundice occur more frequently depending on where in the pancreas the cancer is?
Yes, so jaundice occurs when the tumor is in what's called the head of the pancreas. And in that area, the bile duct, which carries the bile from our liver to the intestine, traverses through the pancreas. And as the tumor grows, and it doesn't need to be very large, it starts to narrow that bile duct and obstruct it. Now, there are a lot of other challenges. I'll mention a few more with pancreatic cancer. So the second challenge is that these tumors, even when diagnosed early, have already disseminated to other organs before detection. So what that means is that surgery alone in those patients who are operable cures less than 10% of patients. And even in those patients who present with a smaller tumor, stage 1 disease, only about a third of them are cured with surgery alone. Now, we improve upon those statistics with the addition of chemotherapy, but still we're only at about 45% cure rate in patients who present with localized operable disease. And then the final challenge is really the inherent, very complex biology of pancreas cancer that not only contributes to the early dissemination, but also renders this tumor just exceptionally resistant to many drugs, not only traditional chemotherapy, but also immunotherapy drugs, targeted therapies. Now, the reasons for this high-level resistance are really quite complex, and again, relate to the very complex biology of this tumor.
And, you know, this is one of those cancers that I talk about and refer to as a cancer where we've made clearly some limited progress. But like the other one I'm going to mention, which is glioblastoma or high-grade brain tumors, it's just a really challenging cancer and has been challenging in all ways. The biology of pancreatic cancer seems to be pretty different from other cancers. I mean, it's extreme resistance to many standard chemotherapies, the fact that there's no real benefit from immunotherapy, and not all cancers benefit from immunotherapy, but many, many do. And is some of that related to the fact that there's just a lot of fibrotic material as part of a pancreatic cancer?
Well, it's complex, but it is true that pancreas cancer cells create this scar-like protective fibrotic shell or armor that impedes the access of drugs and our immune killer cells into the tumor. It fosters an immunosuppressive environment so that our immunotherapy drugs can't work. So that's one of the challenges. But is indeed complex. And I think the very encouraging news is that we are really beginning to dissect this complexity. And this is through basic research, translational research. And I think the more we understand the complexity, the more likely it is that we're going to get to new drugs, as we are currently. So the research in pancreas cancer is really finally starting to pay off.
I mean, there are these new drugs that are being tested very actively in clinical trials. Do you want to talk a little bit about those drugs?
Sure. So historically, pancreatic cancer has been treated with traditional cytotoxic chemotherapy drugs, and that is still the case. We have two regimens that we use. One goes by the acronym FOLFIRINOX. It's a complex 3 chemotherapy drug regimen with a lot of side effects. and then an alternative 2-drug regimen that's a little bit gentler, gemcitabine and Abraxane. Now, both of these chemotherapy regimens have had a positive impact on the natural history of the disease, both in the setting of surgery and increasing the cure rate and extending survival, albeit modestly, in patients with advanced disease. But pancreas cancer, as you know, has really lagged behind almost every other cancer in terms of major therapeutic breakthroughs beyond chemo. So the immunotherapy drugs that we hear a lot about that have been game changers in other cancers, pembrolizumab, nivolumab, ipilimumab, and others, and some of the targeted drugs that we use in a precision medicine manner, they've had a positive impact in many cancers, but have had very little impact to date in pancreatic cancer. But I would say that we are really undoubtedly entering a new era in the treatment of this disease. We have an array of novel agents that are coming into the clinic that are showing great promise. These are drugs that target some of the oncogenic proteins that drive pancreas cancer. We have vaccines now that are looking promising, monoclonal antibodies that are linked to chemotherapy called antibody-drug conjugates that are promising. We have a whole next generation of monoclonal antibodies that are engineered to hit 2 targets that are promising, and then cellular therapies. So I think we really are on the verge of some major breakthroughs finally, and moving beyond chemotherapy for the treatment of pancreatic cancer.
And the excitement is in many areas, although there's a lot of talk about these RAS inhibitors.
So,
is that correct? I mean,
yes,
that are still in trials, not commercially available.
Right. So I think the KRAS story is the most exciting in the last few years. So KRAS is, when mutated, is an oncogenic protein that causes this cancer and drives this cancer to be highly malignant. It was discovered more than 40 years ago, and at the time we knew that if we could shut it down and target it, that it would likely have a positive impact and benefit patients. But it has been elusive in terms of developing targets until the last few years, when with some very sophisticated technology with respect to drug discovery has led to a whole array of drugs that target and inhibit KRAS. Now, we didn't know that would necessarily result in clinical benefit, but as it turns out, we have now shown with multiple KRAS inhibitors, these drugs elicit an anti-tumor response and seem to be clearly benefiting patients. So this is extraordinarily exciting, and really the field is just getting started in exploring when and how to use these drugs and how to combine them with other agents.
And when you talk about it, and this is perhaps the last question before we take just a minute break, but when you talk about KRAS as an oncogene, what you're meaning, I think, is that this is a gene that is driving the growth of the cancer. And so inhibiting that gene is critical for turning the cancer off.
Absolutely. And more than 90% of patients harbor a mutation in KRAS. So if we can target KRAS effectively and elicit an anti-tumor response that benefits patients, that is going to be simply enormous. So this is a very exciting area, and I think we're really looking forward to regulatory approval of one of the most exciting KRAS inhibitors that hits all of the KRAS mutations. We're hopeful that will happen in 2026. It's challenging to get patients into these trials, and so we're really looking for FDA approval so that all of our patients can access a KRAS inhibitor.
All right. Well, that is an encouraging way to leave the first half of the show. We will be back with our guest, Dr. Jill Lacey, an expert in pancreatic cancer, for further discussion about pancreatic cancer, some of the risk factors for pancreatic cancer, and some more on treatment approaches. We'll be right back.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where patients diagnosed with pancreatic cancer are provided easy access to specialized care, including innovative treatments and clinical trials. Learn more at smilowcancerhospital.org. It's estimated that over 240,000 men in the U.S. will be diagnosed with prostate cancer this year, with over 3,000 new cases being identified here in Connecticut. 1 in 8 American men will develop prostate cancer in the course of his lifetime. Major advances in the detection and treatment of prostate cancer have dramatically decreased the number of men who die from the disease. Screening can be performed quickly and easily in a physician's office using 2 simple tests, a physical exam and a blood test. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, where doctors are also using the Artemis machine, which enables targeted biopsies to be performed. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening again, and welcome back to Yale Cancer Answers. I'm Eric Weiner, and tonight we're talking with our guest, Dr. Jill Lacey, an expert in pancreatic cancer, because November is indeed Pancreatic Cancer Month, or Cancer Awareness Month. We were just talking about KRAS, which is an oncogene that is present in, or a mutation in KRAS, or an abnormal form of KRAS is present in over 90% of pancreatic cancers. And we were talking about the fact that there are new drugs that inhibit what KRAS does in terms of promoting growth of pancreatic cancer. I want to stay on this topic for just another minute or two and then talk about some other issues. But so these drugs will come out. Undoubtedly, there will be patients who just have extraordinary responses. And then, as is often the case with new drugs, in most cancers, particularly complicated cancers, some people will benefit from them, and then their cancers will manage to outsmart the drugs. To what extent are people getting ready to look at resistance mechanisms to KRAS inhibitors?
Well, that research endeavor is well underway. We're learning a lot about resistance mechanisms. There are a number of mechanisms that contribute to resistance, and research is already underway looking at ways in which we can delay or overcome resistance. It will probably involve combination therapies, but people were prepared for this based on experiences with other drugs targeting oncoproteins or oncogenes. So I think we're ahead of the game with respect to that question in pancreatic cancer and KRAS.
Well, that's good because, of course, trying to figure out what will be next after KRAS for those who benefit but then stop benefiting is going to be really critical. Can we talk a little bit about risk factors? So pancreatic cancer is one of the cancers that is seen with increased frequency in the setting of certain germline mutations. So cancer genes that people inherit from their mother or father. And of course, as a breast cancer doctor, I'm most familiar with BRCA2. But can you talk a little bit about the increased risk of pancreatic cancer in the setting of inherited mutations?
Sure. So we're on the topic of risk factors for pancreas cancer. I would start by saying that the majority of patients with this diagnosis, their only risk factor is advancing age. Like many cancers, the incidence of pancreas goes up sharply after the age of 60. 40% of patients are over the age of 70. Many are in their 80s, and another 40% are in their 60s. In terms of modifiable lifestyle choices such as smoking, obesity, heavy alcohol consumption, yes, these do impact the risk of getting pancreatic cancer, but the impact is actually quite modest, 1.5 to 2-fold. Now, this compares to a 25-fold increase of lung cancer in smokers. So what I tell patients is you have this cancer. It's nothing that you did or didn't do in your life. This is just something that happens. And in most cases, just simply related to getting into your 70s and 80s. A couple of other risk factors. Recurrent bouts of pancreatitis or chronic pancreatitis is a significant risk factor. And interestingly, a recent diagnosis of adult onset type 2 diabetes is a risk factor. And in fact, really the situation there is that pancreas cancer can cause insulin resistance and can cause diabetes. But the vast majority of patients who are diagnosed with adult onset diabetes do not and will never get pancreas cancer. So we're not screening those patients with the new diagnosis of diabetes. Now,
and let me just ask, long-standing diabetes doesn't seem to increase?
Very minimal risk factor, 1.5-fold increase. Now, you would ask.
I was just going to say, and of course, the reason this is of interest to people is insulin is produced in the pancreas. So there's a natural connection here. But it sounds like the connection is far less than what one might imagine.
Yes, so diabetes is what we refer to, it can be a so-called paraneoplastic syndrome. It's an effect of the cancer on your glucose metabolism. And then with respect to genetics, hereditary factors are extremely important in pancreas cancer. Probably 20% of patients, their risk for pancreas cancer is familial or genetic or hereditary. And we are able to identify cancer-causing genes in about 5 to 10% of patients with this diagnosis through germline genetic testing. And the most common gene that causes pancreas cancer is one that you're very familiar with, and that's BRCA or BRCA. Now, we associate that with breast and ovarian cancer, but it is also the most common genetic cause of pancreatic cancer, increasing the risk anywhere from about 4 or 5-fold to 20-fold, depending on the specific BRCA mutation. So it's actually now recommended that all patients with this diagnosis, regardless of age, stage, or family history, undergo what we call germline genetic testing to see whether, in fact, they carry a gene such as BRCA that they inherited from their mother or father that causes this. Now, why is this important? Obviously, it's important for family members, so first-degree relatives then could be tested. They then could go into a pancreatic cancer screening program because they are known to be at high risk. But it also has implications for the patient. We know that pancreas cancer that is associated with a BRCA mutation responds very well to that more difficult FOLFIRINOX regimen, so we would want to use that. And we also have a targeted drug for these patients after their initial chemotherapy to maintain their response or their remission, a drug called olaparib, which is a drug I know that you're familiar with and is used widely in BRCA-mutated breast cancer. So it's very, very important implications in this disease.
And do you see somatic mutations? So mutations are rising just in the tumor, not in every cell of someone's body, in the setting of pancreatic cancer. Somatic mutations in BRCA2, for example.
Yes, absolutely. We do see somatic mutations in BRCA2. It's not clear that that confers the sensitivity to the platinum, to the FOLFIRINOX regimen, and to PARP inhibitors, and that's a work in progress. We're trying to sort through that.
And what about other gene mutations that someone may inherit? Are there others that are associated with pancreatic cancer?
Yeah, there are a few, but BRCA certainly is at the top of the list. ATM mutations, CHEK2 mutations. It can be associated with Lynch syndrome, which we think about with respect to colon cancer, but that's less than 1% of patients. That is important, though, because those are the patients that should respond well to immunotherapy. So the genetic testing is extremely important.
And since we were talking about genetic testing, and that identifies a group of people at very high risk, let's talk now a little bit about screening. Where are we with screening methodologies? What's done, and does it work?
Yeah, so this is a really important topic for pancreas cancer because I think we feel very confident that earlier diagnosis will result in better outcomes for patients. So we don't screen for pancreas cancer in the general population, and it's not recommended by our professional societies, by the guidelines that we adhere to, and it is not covered by insurance. And this is, of course, in notable contrast to the other common cancers breast, colon, lung, prostate, and cervical, where screening is recommended and has been shown to improve cancer-related outcomes and save lives. So why no screening for pancreas cancer? And there are a number of reasons for this. First of all is cost. So screening entire population for a relatively uncommon cancer, 60,000 cases a year, is extremely costly to our healthcare system. Many tests would need to be done and paid for to detect the cancer. So that's one issue. The screening tests are still somewhat imperfect and not so easy. So a simple CAT scan is simply not sensitive enough. We miss pancreas cancer on CAT scans all the time. MRI scanning is better, but it's more costly and more difficult for patients. The best test is probably something called an endoscopic ultrasound for early detection. That's a minimally invasive procedure with an endoscope. It does require some sedation. It's not completely risk-free, but very, very safe, similar to a colonoscopy and probably easier for patients. I think what we're hoping for is a simple blood-based test that is accurate and sensitive and very specific. We don't want a lot of false positives. That's very alarming. And there's a lot of research into blood-based screening for many cancers. I think we're not there yet, but I think we'll get there. And that will be a huge breakthrough for this disease.
And don't you think that if we could get to a better test, that even though there are only 64,000 cases a year, as opposed to far many more cases of colon cancer and lung cancer and breast cancer, that given the high mortality rate, that you could make a pretty strong argument for screening?
Without a doubt. Those of us in the field are eager for screening for this disease and would be happy to be screening the general population. But it's not possible right now.
Well, hopefully sometime soon. We have just a couple of minutes left, and I want to take this for the last couple of minutes in a different direction. And I want to talk about what it's like to be a doctor taking care of patients with pancreatic cancer. I think people often think of oncologists as having an unusual, sometimes a very difficult job. I think for many oncologists, there's a pretty reasonable mix of patients who do very well and then some who don't do as well. But if you're a pancreatic cancer doctor, an awful lot of your patients don't do well long term. And what's that like, and what's the impact on you?
So we're circling back to where we started. This is a challenging cancer in terms of the statistics, the biology, the outcome. It's a challenging cancer for the caregivers, the entire team, because we know that many of our patients will not do well. And we form relationships with them, and we see the challenges that they face with tumor-related symptoms, with the side effects of the chemotherapy. And so it's difficult. I think, having a comprehensive team to really help our patients is critically important. We work very closely with our palliative care physicians who have a critical role in trying to optimize quality of life for our patients. And we are seeing some long-term survivors in patients with advanced disease. So we have to stay hopeful. And right now, we are seeing these new drugs coming into the clinic. So we're hopeful that we can control the disease long enough so that our patients can access these drugs, which look very promising.
Dr. Jill Lacey is a professor of medicine and medical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.